Yay. Good morning, everybody. We'll go ahead and get started with our couple of intro slides, and then we'll jump right in. We're so excited to have you join us today to talk about facts and fears about xylazine and fentanyl. So remember that we, the California Bridge Program, are a part of the Public Health Institute. We are funded by DHCS. That's where our copyright and our funding comes from. We really appreciate them helping us to do the work that we do. And none of our speakers today have any financial disclosures. We might say brand names like Suboxone when we're talking about buprenorphine. That's not financially driven, just so that you know. It's just habits from us. Can we go to the next couple slides? And we wanted all of you to know, next slide, please, that big question we keep getting about this DEA training requirements. Please don't freak out about it. You only have to worry about it when it's time for you to update your DEA license, and we have got your back. We are working on a really nice library of resources for you that would be no cost. And you'll be able to use those to get your CME requirements. That's for all my docs and nurse practitioners and PAs out there. So stay tuned. We'll get you more when we've got it. But with no further ado, let us jump into the meat of what we are here to talk about today, which is xylazine and fentanyl and a general overview of the drug supply in 2023. So I am Alicia Gonzalez. I am the clinical training lead here at California Bridge, and I am joined by two of my very favorite experts. Like literally, I personally requested these two to join me today, and I will let them introduce themselves individually. Charles, you want to go first?
Sure. Hello, everyone. My name is Charles Hawthorne. I am the Equity and Harm Reduction Project Manager here at California Bridge as part of our clinical program team. So some of y'all might have seen me if you're in hospitals around California supporting you. And then I've also been working in harm reduction for about 6 years now. I have my master's in public health from Johns Hopkins. What else?
Yeah, extremely well-qualified individual. This is like the person I go to when I want to know what's happening out there in the regular community and in the world, and what are people saying, and what should we be ready for. Charles is my go-to. And then Rebecca, please introduce yourself.
Hi, I'm Rebecca Trotzky. I'm an addiction doctor, family medicine doctor in Los Angeles County. And I have this little cutie patootie here. He's my surprise baby of the year. And I'm excited to talk to you guys about xylazine and the pluses and minuses of what we're seeing around California.
Awesome. Thank you. Truly, I am so excited how many people are here. I'm looking through, I see a lot of familiar names. Thank you for joining us. But let's jump right in and start with a fentanyl update. So I know everyone's ready to talk about xylazine, and we will get there, but we wanted to take a beat because last year we did several trainings. We did an emerging trends series about fentanyl specifically. And the take-home message that we gave you at that time was, don't freak out. MAT still works. Start buprenorphine, even if the patient is using fentanyl, and don't be worried about precipitated withdrawal. It's fine. Just give higher doses, give more, add a little benzodiazepine to make people feel better. You can use ketamine if that happens. But in general, we were saying, don't be afraid of it. Keep doing MIT. So Rebecca, where are we at with this guidance? Are there any other messages or corrections or important take-homes specifically about fentanyl that we have learned since then?
So I see fentanyl every day. I see it in people who know they're taking it and people who don't know they're taking it. And we have had so much success with buprenorphine. And I think part of that success comes from being fabulously excited about it. So we are saying, this works, you can do it, and we'll work with you to get through whatever small hiccups we might have. Most of the time we don't have any hiccups, and our patients really join us in that adventure. And usually day 1, day 2, they're feeling so much better.
I want to highlight what you just said, because you taught me this, and I have since proselytized it to everyone, but the expectation setting that with fentanyl use and fentanyl being out there and a lot of patients maybe not knowing that they use fentanyl, I do a lot now of setting it up and saying, hey, the first dose I use might not be enough, but I promise I'm here for you. This isn't going to be a fix in 5 minutes, but if you give me 2 or 3 hours, we will get you feeling better, but you got to stay here and work with me. And I've noticed that setup, like you're saying, that it might take a little longer. We might not know that they have higher tolerances from fentanyl use. They may not know that, but the being upfront about the uncertainty is a huge take home for me. But in general, what doses are you using now when you're starting patients on buprenorphine? What's your go-to?
Yeah. My first starting dose is 16 with another 16 loaded up, ready to go. So I'd say 50% of people who know they're on fentanyl, 16 is fine. They feel fine. and that's like a go-to dose. Maybe later in their day, they're doing another 8 or 16, but there's a couple of patients that you'll do 16, they'll still be in withdrawal. You'll do another 16, they'll still be in withdrawal. You'll do another 16, they'll be slightly better. So it takes a lot more higher doses than what we have seen historically.
And this is a question we're getting like all the time, I feel like out there, what's the maximum dose of buprenorphine that you're allowed to give?
Yeah, there's no maximum dose. And I feel bad as one of the MAT trainers and X-waiver trainers back in the day, we were saying, hey, there's less of an effect of buprenorphine at about 32 to 64. You know, and most people were hearing 24 to 32. And so we were calling that the max dose without really meaning to set that expectation that some harm would happen at a higher dose. There's really been no harm to high dose buprenorphine. It's just, you know, at a certain point, you might not be seeing as much of an impact at the next higher dose. So I have definitely had a patient, you know, on day one getting, let's see, 24, whatever that is. And we still gave another 8 without any worry. So it's okay to go up as long as your patient's getting better.
Yeah, I appreciate you sort of owning that. You know, we California Bridge used to say 8 to 16 was a good starting dose. And I think what I hope everybody here is hearing is that medicine changes, right? Like what we were doing when we were starting patients on 8, people told us we were crazy and that was super high dose and that you have to like micro taper up. So already at that time, doing 8 to 16 was very forward. It was like super insane that we were doing that. And so I think we've learned a lot since then. And I agree with you. I don't even really start with 8 anymore. I'm always using 16. And if a patient self-discloses to me that they're, you know, that they have a high use pattern, like if they say I'm a heavy user, if they use those words to me, I'm going to 32. Like I already kind of know, and I'm an ER doctor, I get distracted easily. So I feel like I don't want them waiting for 3 hours for me to remember to repeat their dose. And I often will just go even higher, but I love that. Yeah, there's no ceiling. There's no like true max dose. It can take multiple doses. I'm seeing a lot of patients continue to withdraw as I catch up, which remember is not the same as precipitated withdrawal. But even if you do, it's not dangerous. Go back and watch that. Any other guidance, like other clinical things you're seeing or tips or tricks you've learned along the way that you'd want to share with anybody?
To just normalize, I think, fentanyl. So I would say some people really don't know they're taking fentanyl or they're surprised by it, and just say, you know, it's really common. Whether or not you know, we just want to be sure that we're treating you safely and effectively and not kind of stigmatize the fentanyl element of the world. And, you know, I think every day, a couple of times a day, we're seeing somebody who isn't knowingly taking opioids. Maybe they're even methadone maintenance treatment and they're not using opioids anymore, but they're using stimulants, and those stimulants have that fentanyl cross contamination, and they're coming in surprised with an opioid overdose, being like, well, I don't use opioids. I haven't used opioids in 20 years. I only use this, that, or the other thing.
Yeah.
So it's really important to just say, you know, whether or not you're intending to use fentanyl, it's really prevalent in our community and we can help you stay safe, you know.
I love that. The idea that, you know, again, this is the same thing we still hear from certain of our sites is we don't have an opioid problem here. If there are drugs in your community, you have an opioid problem. So I think just remembering that and talking to patients about it. I see a question in the chat. This is another myth that I'm so excited that you brought this up, Christine. Thank you. How long do you have to wait? So like she's saying, oh, we used to say, you know, you might have to wait longer, but if the patient uses fentanyl in the morning and they're feeling withdrawal by the afternoon, is it okay to start them, you know, from there in general? Is that too fast? Is there any reason to wait?
Yeah, I honestly, I try to wait if my patient can wait until they're in some withdrawal. And if that means their medical issues are cleared and we're sending them home with buprenorphine in their pocket and I'm calling them the next day, that's okay. I don't need to watch them go into withdrawal for them to start. I can definitely give them the tools for self-care. And we do fentanyl to buprenorphine starts all the time intentionally. In the hospital. So if I have a patient who's been getting a lot of Dilaudid or fentanyl or other things for pain management and it's not working, I do go to that buprenorphine start. And I'm hearing in the chat, yeah, that sometimes we go microdosing, sometimes we go macrodosing. It's really, I haven't seen one be like super more effective than the other in terms of those first few days on ramp. So I think, you know, working with your patient, talking to them about the options, having them make that decision with you and letting them know, like, if I had a time machine to jump ahead 2 days, you're going to be so like set, happy, and glad you're making this struggle right now. It might not be a struggle. It might be super awesome right now. Let's try it, you know, and I'll work together. So I definitely, and working to support those patients.
Yeah. So we're talking also about patients who aren't even aware that they're using fentanyl. And that sort of makes me want to bring up another topic. And Charles, I'm hoping you can update me because you promised me there'd be an update, but fentanyl test strips. So I find myself continuing to say the first things I learned about it, which was like, oh, be careful. They're not very good. You know, like they're the best thing we have, but their sensitivity is not awesome. And like, we get a lot of false positive, false negatives. Where are we at in the world of fentanyl test strips? Are these a thing that we should be recommending now? Are they the same as the original version? Like, where are we at?
So I think that there's two things that I have to say about this. The first one is that there is actually an update. So recently, there's an organization called Dance Safe. So if any of y'all are involved at all in like rave or festival culture at all, you might have heard of Dance Safe. They are a very old organization that has been doing harm reduction work in the party scene for years. And they have recently developed a new test strip that does not have any known false positives. So one of the big challenges with the BTNX test strips, which were the test strips that were most commonly available, and they were the ones that were validated by a few different studies that came out for use by lay people in the field for testing their drugs. They had a known false positive for MDMA and meth. And so you would have to do some pretty severe dilution to get an accurate result for fentanyl sensitivity. Which isn't super helpful when when people don't have a lot of lab experience, when you're telling people, oh, you need to dilute this by 100 times and somebody's doing it in a McDonald's cup on the side of the street. Like it doesn't work. No. So the new fentanyl test strips by Dance Safe, they do not have any known false positives, which is really great. One of the other sides of it, though, is it is a little bit more of a specific test. And so one of the things that's been happening is when these tests, and I'm including this link right here in the group chat, which is to our updated guide to preventing overdose with fentanyl test strips, which includes the instructions for both these old strips and these new strips. Awesome. And so with these new strips, what it kind of requires is having a little bit more specific measurements, which includes having like this tiny little microscope and you measuring out your drug and doing it like that. And if you follow the protocol, then you're in a much better place to be able to know, is there fentanyl present in your drugs or not? So yes, I highly encourage you to take a look at that. And if you are distributing fentanyl test strips, I would encourage you to consider switching over to these and getting these new tools. This is
awesome. This is totally, I had no idea. I'm going to change what I'm telling people. So thank you for this.
The other piece that I do like to add on it, though, is it's not fail-safe. It's, these are all tools that we're using in order to support people the best that we can. And I think at the end of the day, one of the things that's hard to really name is, as a person who I did biochemistry for my degree in undergrad, I have a lot of lab experience. And looking and doing these tests it's lab work. It's legitimate lab work. And if it's done incorrectly, then you get false results that don't necessarily tell you the truth of what you're using. And so really encouraging people to take time and really do these tests well is really helpful. And also just letting people know that it's not fail safe and that there's lots of other knowledge and tools that we have in order to keep ourselves safe, including when people are trying new drugs, using less the first time you use them, making sure that you are using with other people. And just in case you overdose or you have a bad trip, somebody's there to take care of you. Trying to switch your use method. Maybe the first time you use smoking your drug instead of injecting it. Taking care of your body the best that you can, getting sleep, water, food, all those things that are going to set you up to keep yourself as safe as possible. Because by the time that drug is in your body, it doesn't matter what this test strip said. If it's having an impact, it's having an impact. And we need to do the best we can to take care of ourselves in that moment.
I actually really love that advice so much because I think it honors meeting every single patient where they're at, no matter who they are. And that, having a test strip is only as good as your ability to use it. And I know last year when I watched Josh do a demo on how you use it, I was like, I'm a doctor and I find this incredibly difficult to understand. So I think that's, I love to hear that these tests are becoming better tools, but I appreciate you reminding us to honor that like the average person isn't going to be very comfortable with like diluting down and using a strip. And I mean, people misread their pregnancy tests all the time and all you do is pee on it. So it's like a complicated thing, but I want to talk more about some harm reduction because another item that keeps coming up and it's getting, I think, I wouldn't say controversial, but people have strong opinions about is naloxone. And I don't mean naloxone distribution. So we'll put that out there. We all love naloxone distribution. Nobody's against that anymore. I feel like we love this, but I want to talk about dosing, because now, like, moving in sort of to the xylazine topic a little bit, there's this thought like, oh my gosh, you have to give so much naloxone, and maybe it's xylazine and maybe it's not, but fentanyl means you have to give like 20 milligrams of naloxone. And doctors are like, whoa, slow your roll. That's kind of a lot. Talk to me a little bit just in general about naloxone, about the dosing, about some of these controversies. Like where do we land in our opinion about using naloxone?
It's good. I think the name is like, when you think about giving someone naloxone, what they always say when you're screening for someone, if they might be having an overdose, you are coming to them, you're saying, are they not breathing and are they not responsive? If they are not breathing and they are not responsive, chances are they're having an overdose. Like there's lots of things that it could be, but it being an overdose is an opioid overdose is a real reality. Yeah. And giving somebody naloxone, if they are having anything else besides an opioid overdose, likely will not cause any other any counter issues. So it's a good thing to do. One of the things that we're seeing is, especially as people are using more fentanyl, it's requiring more naloxone in order to reverse the overdose. And so we're routinely seeing people needing like 3 or 4 doses of the nasal naloxone in order to reverse an overdose, which isn't necessarily the same as the way that you would give it to someone in a hospital through an IV. It's like 4 milligrams as IV is not quite the same 4 milligrams as like a nasal. So that's like an important thing to note. But, in the field, people are giving nasal naloxone mostly. And so that is something that we're seeing, and that's still a good thing. And, this is one of those things where, like, if you're a person who does reverse overdoses regularly or you see them regularly, I do really encourage you to go watch a reversal video and just kind of figure out the rhythm of things. I think one of the big challenges that comes up is people don't wait long enough sometimes. You have to wait a couple of minutes between each dose to really give it time to hit. And that's especially relevant because if you give people too much naloxone, what you do is you send them into precipitated withdrawal, which can make them feel really sick and really not good. And that's not what we want. We're not being punitive. We're not trying to hurt people. We are trying to help them stay alive. And so really making sure that we're following that protocol is a good way to do that.
I want to highlight what you said about how we're supposed to wait a little bit in between the doses. I think if you've got a 2-pack, that we are sending home, and you want to use both of them, and you're like a person's very concerned that's probably fine. But then you do have to wait a second. I don't know that we give patients that much coaching on it. And then also the idea, like, if you're giving more than one dose and the person's not responding, it's time to call 911 because it could be something else.
Yes, it absolutely is. That's a great point. And it always could be multiple things. It could be an overdose and they're having a heart attack. It could be all types of stuff. And so, it's complicated. Calling 911 in different areas of the state, different areas of the country brings different types of responses. I am of the opinion that like calling 911 and saying, hey, I have somebody here, they're not breathing and they're not responsive. You don't need to say it's an overdose, but that does give you an opportunity to get the ambulance there just in case. And if that person wakes up before the ambulance gets there, they're welcome to leave. So that's just my thought that I have on it. I think the other thing that I like to say, and we're moving into this like Xylazine piece as well, is one of the big things that I'm naming. And this is I'm huge shout out to the team at Punks with Lunch in Oakland, California, that has been doing a lot of really important Xylazine kind of triaging work out here in the Bay Area. And one of the big things that we had a conversation about is, for people on this call who have naloxone, who have Narcan somebody who was having an overdose, people get really accustomed to this, like, you Narcan somebody and they shoot up awake and they're like super aware, like, oh, what the hell just happened? And the thing is when somebody is, and we're going to talk a little bit more about Xylazine, but when we are when people are using both fentanyl and Xylazine, or an opioid and Xylazine, it doesn't always look that way. And so the way that we need to approach overdose prevention shifts a little bit, even though naloxone is still a really big piece. There's a way that we kind of have to go back to our fundamentals of what does it mean to do care for people in the streets, which means that we're really thinking about is monitoring people, monitoring their breathing, instead of just kind of waiting for these big visual cues of what it looks like for an overdose to be reversed.
Yeah. And I love what you're saying. Like the goal is naloxone until they're breathing, not naloxone until they're wide awake and angry, right? So you can stop and just continue supportively watching that person as long as they're not blue and they are having their own respirations. Like that is the key piece. And let's use that as a way to talk about xylazine. So I'll recap a couple of things that I'm hoping everyone on this webinar already knows, which is we've talked about xylazine before, and some of the main take homes we got from that conversation were like, it's actually a veterinary medicine. It's meant for sedating animals, not humans. And there is a reversal agent in animals that is also not approved, for humans. And that drug is not naloxone, by the way. So naloxone does not work to immediately reverse xylazine, but we still recommend naloxone because there's so much dual contamination. Like we're seeing a lot of xylazine with fentanyl or with an opioid in a drug. And so, there are lots of names for xylazine people will use. They'll call it trank or Philly trank or zombie drug or all these other things that we're talking about the same thing. And the difficult part is that it does look and act like opioids in a lot of ways. So the overdose might look the same. The withdrawal pattern might look the same, but it's still not as common or like the item that is killing people as much as fentanyl. So it's concerning and something we want to talk about. But before we dive in, I want to reiterate, fentanyl is what's killing hundreds of thousands of people and the drug that we really need to be the most worried about. But we will dive into xylazine to help make everybody on this call, more comfortable. So if you want to dive in, Charles, I know that you did some local research and reaching out to get a little bit more of what's the beat on the street about xylazine. Tell us what we need to know.
Yeah, so I mean, there's a few different things. So I think that from a perspective, I actually called an old friend of mine who I actually went to prom with in high school, who's an emergency department veterinarian now in Indianapolis, where I grew up. Yes. And when I was talking to her about this, what she said was like, in animals, xylazine is a medicine that's actually used for very short surgeries, like 25 minutes or so. When they use it on horses, these horses like stay standing. For small animals, they like metabolize this drug out in like 45 minutes. So like it shows up very differently in humans. And I'm thinking it shows up very differently, especially when it's combined with opioids. And one of the reasons that that's super relevant is because people, one of the things that I also learned from Ale at Punks with Lunch is people use xylazine. One of the marketing pieces or the ways that people are thinking about xylazine when they're using it is it adds a little bit more legs to fentanyl. So a lot of times fentanyl is a very short acting drug. You get up very fast and you come down very fast. And using xylazine in conjunction with fentanyl allows you to extend out that come down a little bit more. So you're not crashing quite as hard and you're able to enjoy the effects of those fentanyl for longer. And it's a tranquilizer.
I want to pause and highlight what you just said, because I think there's this belief out there that xylazine is only a nasty contaminant and that no one wants it. And what I'm hearing you say is actually there is some desire to have this in there. And like, let us remember, some patients will want this. Like it is on purpose for some people.
That's the same thing we think about fentanyl. It's like, as much as we can sit up here and hoo-ha and have all our moral high ground, people have decisions for doing the things that they want to do. And they make choices all the time. And, in an illicit drug supply, people don't always get a full range of what that choice is. But when we are, that's why we have to do that work of what does it mean to dismantle this war on drugs and really push back on the system that stops people from being able to be fully autonomous in the choices they make around their drug use. But people do make these choices.
Right. And so it gives legs to it. And it is around, what's the prevalence rate, right? Because we hear like, oh, it's not as much here as it is on the East Coast. Like, what did you learn about that?
Yeah, it's still really small. So I know I was talking to the team at San Francisco AIDS Foundation that's doing some work around monitoring the drug supply, and they've just found very little of it. I think that they've like evaluated maybe like 400 samples or so in the past year-ish, and they've only found like 3 or 4 tested for xylazine, and they were in very small concentrations compared to the concentrations that are usually found, like, for example, in Philadelphia and Pennsylvania, where xylazine has been present for years now. The concentrations are very, very high in their drug supply, and they have not been very high here. That's being said, a lot of the community that we have in Pennsylvania did note that when this started, it did start as a bit of a trickle, and then it kind of grew from there. But until that's kind of an issue, right now it's still very small.
Yeah,
it's very, very small.
Okay, so less concentrated, less prevalent here. Yeah, go do it.
Oh, so I was just going to interject. In LA County, we were like, there's very little to zero trank, or that is true. And one of the ways that we found that there was even some was we, as physicians, went to talk to our sheriffs and law enforcement departments who routinely test at a pretty sophisticated level, like, is this white powder baby powder or is it cocaine, right? So they have all this equipment that we also use in medical settings to figure out what's what. And they had been saying that they had seen xylazine in our communities very rarely, very sporadically, even a couple of years ago. So preceding all of our physician awareness and healthcare awareness, the law enforcement community had this awareness. And interestingly, they didn't think anything of it. They weren't like, oh, we should go tell our public department, or, oh, we should let our hospital teams know about this. So not that I say go talk to the law enforcement routinely, but it might be worthwhile to think in your community who could broker that conversation with law enforcement to see if they are doing testing and routinely seeing some xylazine and how often they are seeing it, and ask them to start recording it. Like the law enforcement community wasn't even like, oh, we should know how often. Is this once a year, once a month? They weren't even able to tell us. So it might be worth it for you guys to just touch base with them.
That's so brilliant. Like, how often do things get lost in translation? It's possible that your local public service, agencies might know about this stuff and just haven't had a chance to tell you or didn't think that you didn't know. So reach out and ask. I love that. And then we talked about, some harm reduction stuff with fentanyl. I think I want to reiterate again that the goal of naloxone is to get somebody breathing again, right? Not necessarily to get them all the way awake so that's when you can stop. But on that same vein, are there xylazine test strips? And if there are or are not, what's the summary there? What should we expect?
I think that my general summary is not quality ones. I think something really important that I do want to say about test strips and what does it mean to be doing harm reduction in 2023 is there's a lot of people who are trying to make money off of this, who are going to try and sell anything. And there are people who have developed xylazine test strips who are going to try and sell them to you as a harm reduction thing. Number one, you need to make sure that things you're purchasing are validated. I don't always believe in the academic structure being the most validating structure for it to exist, but you need somebody to say it works. Yeah. And what we've seen from these xylazine test strips is they do not test at a concentration that is appropriate to be able to assess if it's a safe drug or not. So for example, if the concentration that they can test for is not sensitive enough for how strong it is when it enters your body. So if you test for this strip, it might say like, oh yeah, it doesn't have any xylazine in it because it's not strong enough xylazine for it to register on the test strip. It still isn't enough xylazine for it to influence your overdose. So it just isn't helpful. And so we're not recommending people buy them. We're not recommending that people recommend them for people in the field.
Perfect. That was so definitive and I really appreciate it. And you said one thing that got a very positive comment in the chat. And so I want to, if I can, ask, I don't know, I don't think this is controversial, but certainly it is. I'm going to lean into a little bit of a controversial topic for a second, because I think that what you were just saying a little bit ago about people having agency and making their own choice, and something that is, certainly on my mind, is about how are we overall, like thinking about all the contaminants like fentanyl and xylazine, and how, there is really an uncertainty to this drug supply because it's all illegal. Mm-hmm. Without getting too political, but thinking about our patients in like a person first conversation, I want to unpack a little bit what you think the solution to this is, or what is, like, if we're being honest, what is the long-term view on how this drug supply continues to change and affect people?
Yeah. I mean, I think the truth of the matter is like, as long as we are operating in a world that has an illicit drug supply, this is what continues to happen. Yeah. Like when this is something that's happened time and time again, like as people who are making these drugs and manufacturing these drugs shift, as long as there's money to be made off of these drugs in an illicit context, there's always going to be limits in what we can actually know and what we're purchasing and what we're using. And that's true for people buying things on the street. And that's true for people hitting up somebody that they know to buy Molly or whatever from their local person who sells. And so, like, as long as we're moving from a place of criminalization, that's always going to be the problem. And it's been fentanyl. Fentanyl has devastated and their community, our country, in the ways that it's impacted overdose. And next, it might be xylazine. It might be something else. It might be another thing that's coming through. There's been all different types of contaminants that have showed up in different drugs and different drug supplies over the years. But the reality is, as long as drugs are criminalized, they're going to continue to be produced and sold in secret. They're not going to be regulated. There's not going to be a way to accurately test what's going on. As long as the procedures that we have to test them are criminalized as well. that's just always going to be the problem. So there's a level that part of the work that we're doing is we're actually trying to save people's lives. There's an important part of working towards decriminalization, because we can't actually do our public health work in a criminalized context.
Yeah.
And then there's also a level of what we're really focusing on right now is keeping people alive, and criminalizing people is really working against that, because what it does is, from a legal standpoint, it puts people in a place where they're uncomfortable disclosing these things. And if we are moving from a place of trying to criminalize and shame people for their drug use, they don't want to disclose it to us as the people who are supposed to be helping them.
Yeah. And I think I appreciate you being willing to say all of this, because I think for some people who hear this, it might be an uncomfortable topic. It might not be the politics that you align with, but I think that there is an honesty in, as long as these things are illegal, they will remain illicit, and therefore non-controlled, non-monitored, non-tested, non-filtered, non-whatever, right? And we're always going to see, first it was fentanyl, now Xylazine. And I'll be honest to everybody on this call, like there have actually been like 20,000, it feels like, other contaminants that we just didn't talk about as much in the media, or maybe weren't as prevalent, but contaminants are real, and they're just going to continue being present. It's going to continue being unsafe. And so however we feel individually about whether, people should or shouldn't use drugs, they do. And people are going to make a lot of decisions that you don't agree with, or that I don't agree with, or that, whatever, or maybe you do agree with it. But that as long as we are coupling, people's choices with things that are criminal, we don't have the ability to make them safe. And it makes that harm reduction piece of this work so much more important. I know we're at time, but Rebecca, can you please share just briefly that link that you put in the chat? Can you say that out loud so everybody sees it?
Yeah, there's an organization called Homeless Healthcare LA, and there's other organizations in the country and internationally providing oxygen in communities that have high density overdoses, not just naloxone distribution. And it's one way that you can deal with the adulterants and Xylazine, where it's not going to be reversed as quickly or with naloxone, but you can provide supportive life-saving care with oxygen. So it does end up saving lives, and you can do some trainings and have oxygen tanks in the community. And this is how some of the high prevalent areas of Xylazine have been managing to reduce some death rates. And I think it's an option for many of us to consider. We have this available in our hospitals and our ERs, and we do it all the time. And what would it take to bring this into other communities, and when would it be really useful? So I want to share that there are options that are being explored, and it's been working well for some communities.
Yeah. And I think another important part is there isn't really a naloxone equivalent for Xylazine that works the same way. It's kind of one of those things that, like, I think that people are figuring that out. Like, emergency medical doctors are always on the forefront of seeing, like, what works with this? Let's try this out. Let's see if this is happening. But, there isn't necessarily like a naloxone for it yet that is working on the same system in the same way, that's knocking this off the receptor in the way opioids do. Drugs are not drugs. Like, everything works on a different way in our body, and our different way on our nervous system, on our central nerve, on all different types of our body systems. And so there's a reality of that. And then I think the other big piece, like I said earlier, is when we have an accustomed way of thinking about what it looks like to reverse an overdose, and we're used to people shooting up and being super awake right after an overdose is reversed. And that's not happening anymore. What happens is people give more and more naloxone. And so you've heard these stories of people giving like 6, 7, 10 kits of naloxone. And they're like, it's not working. They're like not waking up. And it's like, okay, well, let's take a step back. Because, we're not always there. There's not always somebody there that's maybe a little more trained in this, or a medical doctor when it's going on. And so what can happen a lot of the times is people just give way too much naloxone, and it puts people in precipitated withdrawal while they're on a tranquilizer, which means that person is asleep, and you're putting them in precipitated withdrawal, which puts them in a position that if they throw up, if something happens and they're not able to turn or move, it can be really bad. And so really focusing, like I said, on breathing, focusing on monitoring people, putting people in the rescue position, just good, like, street first aid. Like, that is what it really is. And I love this, people going around with oxygen tanks. I think it's super great. Like, I think if you're doing a lot of this work, looking into getting ambu bags, looking into getting mobile blood oxygen monitors, things like that, that'll actually give you a little bit more of the tools to monitor this. And that's maybe the way that we'll have to adapt as we're kind of moving through this. And just being super conscious that overdoses don't always look the same. And that's the truth of like a meth overdose doesn't look like an opioid overdose.
Right.
An alcohol overdose doesn't look like a cannabis overdose. And so that's just kind of the adjustment that we're making.
Yeah. And I think what I want to pull out from what you said and to address some comments in the chat, like the reason that we brought this to you, and we are at time, don't worry, I'm wrapping up right now, but is clearly there's a lot of uncertainty, and new things like Xylazine make doctors feel uncomfortable, and makes everybody feel uncomfortable because it's not in our wheelhouse. It's not a tool we understand. So I'm seeing comments like, our doctors think that atropine and epi is the treatment for Xylazine, and these people say give high dose naloxone. Like, none of that is right, but it doesn't mean people aren't trying. And I think the take home message here is, so far, there is no magic solution for Xylazine except for supportive care. So oxygen, making sure they're still breathing in a place of comfort, not in a dangerous space where someone can take advantage of them or steal from them or harm them while they are sedated. Those things are important. So remember, everything is fentanyl. Everything is fentanyl. If a person is using drugs, they're probably using fentanyl without realizing it, or maybe on purpose. Don't be afraid of higher dose of buprenorphine. Start with 16. Let's start to eliminate that 8 milligram dose, unless somebody's like, oh, I use this or that tablet, like, and it's prescription medicine misuse or something like that. But in general, usually we're going to be starting with 16, maybe 32 milligrams. There is no ceiling. Don't be afraid of going high. There's no arbitrary limit. You can keep going. You might need more naloxone than you're used to, but the goal is breathing, not wide awake and walking out the room. So more naloxone is okay. Wait 2 to 3 minutes in between doses. You can two doses of nasal spray, give it 2 or 3 minutes, wait for breathing. The goal is breathing. Fentanyl test strips are getting better. Recommend them, use them. Do not ever use alone. Have somebody around, or call that never use alone hotline so that you can make sure that if you do overdose, someone is there to send emergency responders to you. Xylazine is starting to grow in prevalence. Mostly though, it's just supportive care we're looking for. Try naloxone, but monitor for breathing, keep people comfortable and safe. At the end of the day, the bigger picture, we're going to keep dealing with a lot of contaminants as long as the drug supply is illicit. And so here we are. We'll be here to help keep up with all the changes. If you need us, you can find us at the California Bridge Resources. Go to this QR code, cabridge.org/resources. And if you want us specifically, you have more questions we didn't answer, info@cabridge.org, info@cabridge.org, and we can answer all those questions for you. Thanks so much for being here. Big thanks to Charles and Rebecca. I adore you too, and I so appreciate you taking the time. And we'll see everybody next time.